Hi, I'm Dr. Doghmi. I'm a cardiologist. Let me just introduce myself. I have been in the United States for almost 20 years. I finished my medical school in Jordan, in the Middle East. I did my internal medicine residency in Seton Hall University in the United States, and then I did my fellowship at Louisiana State University in New Orleans. So I'm a big fan of the Saints and LSU.
We'll forget it.
So I'm still not used to the Michigan State. So I am board certified in internal medicine and in adult cardiology, and I have the International Board of Heart Rhythm Management, which deals with arrhythmias and pacemakers and defibrillators. And I'm also board certified in echocardiography and nuclear cardiology. I'm happy to be here tonight to talk about prevention of cardiovascular disease. I'm going to try to talk for 10-15 minutes, and then we will make it a nice meeting with questions and answers. Maybe we will learn from each other. Coronary artery disease is a very common disease. It's the #1 killer of people in the whole world now. Around 15 million people die every year in the world from coronary artery disease. It's one of the major problems in the health system in many countries, and now it's becoming a problem for the developing countries. The more they become westernized and they eat our food and they use the technology that we have, they don't exercise, they don't walk, they eat big portions. There is an epidemic of diabetes and obesity in the whole world. So the coronary artery disease is catching up even with developing countries like India and China and Africa and the Middle East. And it's a big problem for the United States health system. It costs the United States billions of dollars every year just to deal with this disease alone. Unfortunately, coronary artery disease nowadays is being recognized as a disease that starts early, much earlier than we used to think. We always thought about coronary artery disease as a disease of patients in their middle age and a disease that will catch up with you after retirement. Nowadays, we find out from research that the problems with atherosclerosis, which is the background of coronary artery disease, starts at a young age. There is evidence that the early precursors of atherosclerosis can be found in children less than 5 years of age. We call those the foam cells, and after the foam cells form in the lining of the arteries of the heart, we start developing what we call atherosclerosis or plaque formation. And we found about this by doing post-mortem studies on younger children and adolescents who die from other reasons. And unfortunately, the disease is also spreading very fast in our country because of the epidemic of obesity and diabetes, and especially childhood obesity. All those kids you see around in stores or around your house playing, and they are overweight, they are already carrying the risk of having coronary artery disease when they grow up. So now we have to concentrate our prevention on even in children and in adolescents. And I'm sure you heard about campaigns to encourage kids to exercise and to encourage a healthy diet in schools, and to cut the portions of fatty foods, and to check children for diabetes. The precursors of atherosclerosis are very simple. There are major and minor risk factors that constitutes the basic background of atherosclerosis. I usually like to draw pictures when I talk. It makes things much easier to understand. So the atherosclerotic process starts in the wall of the coronary artery. And the human heart is like any muscle in the body. It gets the blood supply from 3 major arteries. 2 on the left side, they come from a main artery, we call it the left main. And this artery bifurcates into 2 arteries. One is called the LAD, or the left anterior descending artery, and the other branch is called the circumflex artery. And each one of those give different branches. The right coronary artery comes from the right side of the aorta and supplies the right ventricle and the inferior wall of the heart usually. So these are the 3 major arteries of the heart. And in the wall of the arteries of the heart, we have a lining. We call that lining the endothelium. And this is a very complex structure. One of the most complex organs in the whole body is the endothelium. That is the lining of all our arteries and the veins. What we noticed, or what the research found out, that there are risk factors that starts the process of inflammation and what we call foamy cells formation, which are macrophages that eats or engulfs the bad cholesterol that runs in the artery, and then tries to penetrate the endothelium and settle down in the artery itself, forming what we call atherosclerosis. And the atherosclerosis grows to become what we call a plaque. And the plaque usually takes part of the artery and forms a blockage inside the artery. And for a reason or another that we don't understand, there's an inflammatory process going inside this plaque. The human body understands this inflammation, and this is as a strange process that's not natural. So the human body summons all the defenses to fight this plaque. White blood cells, smooth muscle cells, and also summons the strongest element in the body, which is calcium. And calcium starts also building up around the plaque and in the wall of the artery. There's an inflammatory process going here with white blood cells and macrophages. And then you have the fibrous tissue forming, and most of the plaques, they end up having what we call a cap. And for a reason or another, with emotional stress, with certain kind of activities, mainly isometric exercise, if you increase the shear forces that you subject this cap to, the plaque will rupture. And once the plaque is ruptured, it will be exposed to the bloodstream. And in the bloodstream, we have platelets. So the platelets form a clot on top of the plaque. So if you have a ruptured plaque, all of a sudden, the platelets and the blood and the clotting factors are exposed to all this stuff inside the plaque, and you form a clot. So you will have a clot on top of the plaque. So on top of the plaque, you have a clot that forms, and it will result in one of two things: either total occlusion of the artery, and if you have total occlusion of the artery, you have what we call acute myocardial infarction, or acute ST elevation myocardial infarction. The artery is going to supply a certain part of the heart muscle, and all of a sudden there is complete occlusion of that artery. So you will start the process of necrosis and death of that part of the heart muscle. And that's what an acute myocardial infarction is. If you don't have complete occlusion of the artery, you might develop what we call ischemia. And if the results of the ischemia is a deprived part of the heart muscle from oxygen, you might also have a heart attack that we call non-ST elevation myocardial infarction, or non-EQ wave myocardial infarction that we used to call. If you only have a plaque without an acute rupture, and the plaque started to grow to cover more than 70% of the artery lumen, then you will start having chest pain with activity or with emotional stress. We call that angina, due to imbalance between the supply and the demand. At rest, while you're resting, you have a 70% or 80% plaque in one of the arteries of the heart. When you are resting, that part of the heart muscle is getting enough blood supply from the 20% lumen that's left. But if you start exercising, and that part of the heart muscle needs more blood supply, more oxygen, you will have a deficiency in the blood supply because you have an 80% blockage. So that part of the heart muscle becomes ischemic, and you start having chest pain. So one of the commonest signs and one of the commonest symptoms of what we call acute coronary syndrome is chest pain. People usually present with chest pain that comes with activity or goes away with rest, or chest pain that usually happens with emotional stress. Some patients, they don't have the classical symptoms of chest pain, especially women, patients with diabetes, and the elderly patients. Those are three groups of patients. They have atypical symptoms. They can present with chest pain, but they sometimes present with symptoms like shortness of breath in diabetic patients. We call that angina equivalent symptoms. Or they present with symptoms that are not related to their chest. Jaw pain, back pain. Women, sometimes they present with nausea and vomiting and not feeling well or weak or tired. All these symptoms, if you suspect that the patient have coronary artery disease, you need to keep at the back of your mind to make the diagnosis. What are the major risk factors for this process? There are major risk factors that you cannot change. One of them is your age. The older we get, the chances that you will have atherosclerotic process going on will go on. Number two is your genes. So if you inherited some genetic factors that will accelerate this atherosclerotic process, this is something you cannot change. You cannot change your race. You cannot change also your socioeconomic status in a way. So if you are used to live in poverty and you eat whatever is available to you, and you don't have the luxury to eat healthy or exercise, then these things you cannot really change. On the other way, there are risk factors that you can change, and those are called modifiable risk factors. On top of the list, we have high blood pressure, hypertension, hyperlipidemia, high cholesterol, diabetes, obesity, exercise or lack of exercise, smoking. So those are modifiable risk factors. You can change them if you choose to, in a way. So if you smoke, you can quit smoking. If you have hypertension, you can take medications. You can work on losing weight, follow a low sodium diet, lose weight and exercise, and take your medications on a regular basis. If you are diabetic, you need to be careful, because patients with diabetes are considered at a high risk of cardiovascular events much more than the patients who don't have diabetes. In fact, we consider patients with diabetes equivalent to patients who already had a cardiac event or coronary artery disease. That is well documented. So a patient who comes to us with diabetes, he is equivalent to a patient who just had a heart attack or survived a heart attack. That's how much we don't like diabetes. Obesity is an epidemic like we talked about, and then exercise or lack of exercise, living a sedentary lifestyle, using your car for everything you do and not exercising on a regular basis. The recommendations for exercise nowadays should be at least half an hour to 60 minutes most of the days of the week. And some studies showed that patients, or it was done on retired people in fact, they found any retired person who walks briskly, faster pace, 2 miles a day, they live longer than the same retiree who just doesn't exercise. So you have a survival benefit, even from exercising. So those are the major things that we usually talk about. Hyperlipidemia is one of the major risk factors. The total cholesterol in the body is divided into 3 subgroups. The bad cholesterol, or the low density lipoprotein, which we call LDL, and the good cholesterol, which we call the HDL, or high density lipoprotein, and the triglycerides. The LDL is the atherogenic, or the bad cholesterol that we call. The HDL is the good cholesterol, which is a little bit protective. And the triglycerides, they are also atherogenic, but to a lesser extent than the LDL. So when we treat patients with hyperlipidemia, we usually concentrate on, number 1, lifestyle modification. We tell the patients to work on losing weight, change their diet, follow a low-fat, low-cholesterol diet, try to eat a lean meat, try to avoid the skin of the chicken, for instance, buy the leanest meat you can get, avoid high-fatty foods. And after we treat the patients with diet for a few weeks, if we see no improvement in their LDL, then we choose to treat them with medications to cut the risk of coronary artery disease. After we treat the LDL, then we pay attention to the high triglycerides. Some patients, they have high triglycerides to start with, so we have to address the high triglycerides to start with, regardless of because their LDL usually is within acceptable limits. Hypertension is also a major risk factor. Both systolic and diastolic hypertension is very important, and we use, some people used to say before, it's the top number or the lower number is more important. Both of them are important. And also, hypertension is also related to your weight and your exercise capacity and your lifestyle. So if you follow a low sodium diet, if you lose weight, in some studies, if you lose weight, significant weight, you can drop your blood pressure anywhere between 10 to 20 points just with weight loss and following a low sodium diet. And then you need to take medications for the hypertension. And one of the major issues that we face with patients with hypertension is that after they take the medication and the blood pressure is normal, they stop the medication. They believe that this is a one-time thing. So they go home and they take the medication, and once their blood pressure is normalized, they stop taking the medication. Like a patient who has diabetes, they take insulin or medications for diabetes. Once their hemoglobin A1C is good, they stop the diabetes medications. They think that the goal was to bring these numbers to the normal level and then you stop. So you have to continue your treatment because these are lifelong diagnoses, kind of. So this is just a quick review of the risk factors, the process, the pathophysiology of atherosclerosis and coronary artery disease and myocardial infarction. And I will open the door for you guys to ask questions. Please feel free to ask personal questions if you don't understand something, or if you are taking a medicine that you don't know why you are taking it, and I'll be happy to answer them. If you don't ask questions, I will ask questions.
I have a question. When you were talking about the young child being heavy and they'd already started, so in their life, if they become active and lose weight, will that disappear, that plaque that had started
Yes.
as a child? Okay.
Yes, most likely they will have some reversal of that process, but we need to start early before they develop a plaque formation, because once you develop a plaque, it's very difficult to reverse the plaque. But if you change your lifestyle early, you pay attention to their diet and their exercise. One of the major issues, they don't exercise anymore. They're all playing video games and watching TV. So the recommendation is nowadays to limit their TV time to 1 or 2 hours every day and engage them with activities outside the house or inside the house where they are very active. And they need to keep an eye on their weight and their diet. That's very important at an early age.
So the answer was that obesity in a child, that if when they get into their teens and through there, that it would reverse, that the plaque had not.
Yes.
I guess that's how bad the plaque is.
Exactly, and that's why we are seeing patients now in their 20s and 30s with coronary artery disease. 25 years old and 26 years old presenting with a heart attack. Well, several years ago we used to see 45. So the age is, because the process is starting earlier, much earlier.
Is there anything a person can do once a plaque starts to form to get rid of it or dissolve it?
Some studies showed some regression of the plaque with statin therapy, like Lipitor and Zocor and all these medications. We call them statins, that lowers the LDL. But the regression was not very significant. What you can hope for is that you keep that plaque stable. So now there is a term that we use, a stable plaque and unstable plaque. The unstable plaque is the plaque that is vulnerable to be ruptured and causing an event, or clotting basically, and forming a heart attack or sudden death or an arrhythmia. Once the plaque is fibrosed and calcified, most likely it becomes a stable plaque. But if it's still a soft plaque with no calcium, and if the patient continues to have their risk factors unattended, then most likely these plaques will rupture and they will end up having an event. What we mean by an event, either a myocardial infarction or sudden death. So that's all what you can do for the plaque that has already formed, to make it stable and to prevent a new plaque formation in the other segments of the arteries. One of the major issues I would like to raise also is around 32 to 35% of patients with coronary artery disease, they have carotid artery disease. And around 30 to 35% of patients with coronary artery disease, they have peripheral vascular disease. So 1/3 of the patients have carotid artery disease, 1/3 have peripheral vascular disease, which tells you that atherosclerosis is a vascular disease that involves all the segments of the vasculature in the whole body. In the arteries, if it affects the heart, we call it coronary artery disease. In the neck, we call it carotid artery disease. In the legs, we call it peripheral arterial disease, PED, or peripheral vascular disease, PVD. So those are also things that we check for when we have a patient with a documented coronary artery disease. So when you take care of your risk factors, you're not just stabilizing the plaque, you are preventing the atherosclerotic process all over the body, preventing peripheral arterial disease, carotid artery disease, because they have the same risk factors. Go ahead.
I was just going to ask, how can you tell if it's stable or unstable? How do you diagnose that?
You can't tell. There are studies and different imaging techniques that we use to tell which is the vulnerable plaque, but this is still, the research is going on right now. But we know from studies that plaques that are calcified, they are more stable than soft plaques, for instance. And you can see those with cardiac CT scans mainly. When you do a coronary angiogram, you don't see the wall of the heart. You see what we call the lumen. So cardiac CT scan that started in the last 10 years or 15 years started showing us the wall of the artery and the calcium burden that involves the walls of the heart in a process we call remodeling. Sometimes the plaque will form and the artery will dilate outward, so the lumen will not be affected, but you will have heavy calcification of these plaques outside. And this is those plaques usually they don't rupture. They are not associated with events. Plaques that are mixed plaques, calcified, and they have fibrous tissue and soft elements, they are the ones that are usually found in patients who have acute coronary syndrome. If you check those patients acutely when they present with an acute coronary syndrome event, like a myocardial infarction or unstable angina, then you will notice that you will have the mixed or the soft plaques rather than a calcified plaque. But this is eventually, it's a developing science, and hopefully one day we will have a test that will tell us which plaque we expect to rupture. Then we can guide our treatment, and that will help us to prevent such an event.
Thank you.
How does a cardiologist determine whether the best treatment is a stent versus coronary bypass surgery? Is there rules of thumb that say a stent is better or a bypass is better?
Yes, we have studies and we have guidelines. Most patients who have a single vessel disease that does not involve the left main artery or the proximal LAD, usually they benefit from stent placements or angioplasty, followed by stent placement. Most cardiologists nowadays, I would say, they will refer patients with left main disease to have bypass surgery, because the left main artery, let me draw a picture. So on the left side of the heart, we have a short artery, we call it the left main. So this is the LAD, the left anterior descending artery. This is called the circumflex artery, and this is called the left main artery. And on the right side, we have the right coronary artery, which we call the RCA. So most cardiologists nowadays, if you have a left main disease, we recommend bypass surgery. Although there are studies nowadays going that showing that angioplasty and the stent placements, even of the left main, although it's a high risk procedure, is also feasible procedure, let me put it that way. Feasible means it can be done, but it's not the stand or the guidelines right now. If you have a disease that involves the bifurcation of the proximal LAD and the circumflex, most interventional cardiologists will shy away from doing angioplasty or stent placements, and they will proceed with bypass surgery. The major difference between bypass surgery and stent placements or angioplasty is that the complete revascularization of the heart should be the target or the rule. For instance, if you have 3 vessel disease, if we have 3 blockages, one significant blockage is in the circumflex, the LAD and the RCA, most patients, they go for bypass surgery because you want complete revascularization and for the whole heart. Those patients with 3 vessel disease, they do better on the long run than patients who have balloons or stents. The difference is mainly with the revascularization process. If you get balloons and stents, you will have too many stents, too many interventions, and you might come back within a year or 2 and you have more procedures. Patients who get bypass surgery, they live long without the need for revascularization. Patients who have left main disease or proximal LAD disease that is difficult to manage by angioplasty and the stent placements, they do better with bypass surgery. Patients who are diabetic, they do better with bypass surgery. Patients who have 3 vessel disease and they have abnormal heart function or left ventricular dysfunction, we call it. The ejection fraction is low. They do much better with bypass surgery because you provide complete revascularization and improvement in the blood supply to the whole muscle. So those are the general. Of course, you have to take into consideration the patient wishes. That's number 1. Even if the cardiologist will recommend bypass surgery, you can, if it's feasible to do angioplasty, but you need to understand the risks and benefits of each one of them. But there are certain things like left main disease, 3 vessel disease in patients with diabetes, LV dysfunction. The majority of cardiologists will agree that bypass surgery is a better option for the patient. So these are the things that we take into consideration. And also we need to take into consideration the expertise in your area. If you have a good surgeon with good results, if you have a good interventional cardiologist with good results, that also plays a role. And the volume of patients they do. That's why we recommend I recommend for my patients to go to a busier hospital with a large volume with good results, so they can get the best odds on their side, kind of.
What is it when you do bypass surgery? How does that work? I mean, it sounds like they're bypassing
the 3 arteries. The main artery that bifurcates to the circumflex and the LAD and the right coronary artery, they come from a major artery which is called the aorta. Okay? Mm-hmm. If you have a blockage in the LAD here, or in the RCA here, and the circumflex, what we usually do for the LAD, if we can, we usually take the left internal mammary artery, which is like a spare artery that God gave us, and we discovered that we can use. We redirect it from the chest wall, and we hook it. So here is the mammary artery, comes from here, and we hook it to the LAD after the blockage. So we are bypassing the blockage. So this area of the heart that was not getting a blood supply because of this blockage, now is getting blood supply this way. For other arteries, the RCA and the circumflex, we usually take veins from the legs and we reverse them, because the veins in the legs, they have valves. And the valves are facing this way, up, to prevent the blood from going to the legs, so we will not have swelling. So when we do them, we hook them to the aorta here. We flip them upside down, kind of. And we hook them to the circumflex artery and to the right coronary artery. We call that a reversed saphenous venous graft. Saphenous vein is the vein in the leg that we take this, we harvest these veins from, and we hook it to the aorta, and we hook it beyond the obstruction. So this part of the heart muscle will start getting blood supply from the aorta this way.
That's amazing. That is amazing that you can do that.
Those bypass grafts, after you finish your bypass surgery, you need to pay attention to, or you get an angioplasty or stent placement, you need to pay attention to them like your original native arteries, because they will develop atherosclerosis also. And then usually we deal with them with balloons or stents if they form blockages. And sometimes patients, they end up having another bypass surgery. We call that a redo bypass surgery. So all the grafts fails, or the majority of them fails, and the patients continue to have symptoms. They end up having a redo bypass surgery, where we take more veins, or we use the radial artery, we use another artery in the chest we call the REMA, the right internal mammary artery. So we have the left, the LEMA, we have the REMA, we have the radial artery, and we have the saphenous venous grafts from the legs that we can use as conduits to provide blood supply beyond the blockages. If you end up having balloons or stents, here is a blockage. And if you have a plaque here, more than 70%, what we usually do is we bypass the blockage with a wire. So here is a wire. On top of the wire, we pass a catheter, and at the tip of the catheter, there is a deflated balloon. And once we reach this area, so here is my catheter. I have a deflated balloon next to the plaque. We inflate the balloon. That's what angioplasty is. When we inflate the balloon, we crush this plaque against the wall of the artery. So when the balloon is inflated, like this, it crushes the plaque against the wall. So the plaque will be something like this. So this is the result usually after angioplasty. What we notice is that most patients, they come back with restenosis because the artery recoils at itself after you deflate the balloon. So what the scientists discovered, they discovered the stents, which is a metal meshwork, it keeps the artery from recoiling on itself. So with another catheter over the wire, we introduce a stent, and we deploy the stent inside the artery. And the stent will keep the artery from recoiling on itself. If you don't pay attention to your risk factors, you can have problems with the stent. You start having blockages inside the stents. There are two kinds of stents. Stents that are not medicated, we call them bare metal stents. Those are the original stents that were discovered. We noticed around 20 to 30% of patients within a few months after the procedure, they come back with angina or heart attacks. And we found that those patients, they react to these stents and they form a scar tissue inside the stent. We call that in-stent restenosis. And the scientists thought about this process, and they found that if they medicate these stents with microscopic bubbles on the stents that releases a chemotherapy agent slowly in the circulation. We prevent that scar tissue from forming. And that's what we call drug-eluting stents. That's what the drug-eluting stents, or the new stents, most patients they call them. The difference between the management of the patients after they get an angioplasty or stent placements is not different from the original disease. We also add what we call antiplatelets. So if you get an intervention, usually you end up being on an aspirin. Usually we recommend the aspirin indefinitely for the rest of your life if you have an intervention. If you get a bare metal stents, we usually recommend another medicine, another antiplatelet, like Plavix. Most patients that take Plavix. Usually we use this for 6 weeks, 4 to 6 weeks after the stent. If you have a drug-eluting stent, we recommend aspirin indefinitely and Plavix for a minimum of 1 year. So that's what we recommend usually. So this is how we approach this issue with the intervention. Any other questions? Those are very good questions.
Just one more.
Go ahead.
When you do a bypass, what happens to the original artery that you're leaving behind? Do you just leave it there, or do the surgeons cut that part out, or what?
No, we leave the artery the way it is.
Okay.
In fact, in the future, sometimes you are faced with patients, if you have a failure in this graft for a reason or another, the graft is totally occluded, and the patient continues to have chest pain, we go after the native artery and we try to open this with a balloon or a stent. So the surgeons don't cut the original native artery.
Why do we not use the left mammary artery for other vessels besides the LAD?
The LAD is the major coronary artery. It supplies more than 40% of the total myocardium.
Right.
So we use the most precious gift that God gave us, which is the lima, that has a very low incidence of closing, not like the saphenous venous grafts. We use it for the most important artery.
So you save it in case you need to use it again?
Exactly.
Okay.
So if you have to choose, you will use the lima to the LAD, because that's the most important artery that you would like permanent revascularization for. Because the chances that the mammary artery closes is very, very low in comparison with saphenous venous graft that you take from the leg. That might close within a few years, or 10 years, or 15 years. The lima usually lasts lifelong. Of course, you have to take care of your risk factors.
Why is it? Because the inside of the
lining of the mammary artery is different from the saphenous venous grafts.
Okay.
So first of all, it's an artery. So you are bypassing an artery with a stronger wall and a good endothelium. The saphenous venous grafts, they have valves, and they have a tendency to form atherosclerotic process faster than the mammary arteries.
Okay.
Any other questions? Good. Thank you for coming, and enjoy your coffee and your cookies.
Well, thank you very
Thank
much
you.
for coming.
Thank you. It's
you.
very informative.